Hi, everybody, and welcome to our latest episode of Meet the Researcher. I'm excited to be joined this morning by Dr. Naris Nilubol. Dr. Nilubol is the Chief of Endocrine Surgery Section of the National Cancer Institute at NIH. He is also the principal investigator of the VHL-related pancreatic protocol being discussed today. Dr. Nilubol has over 110 peer-reviewed publications and several book chapters and is currently working on a VHL-specific book with Dr. Deval Patel. Dr. Nilubol, thank you for joining us.
Thank you. Good morning. Welcome everybody to our mini series of lectures today. As you know, my specialty is about pancreas-related issue that you could see in patients with von hippel-lindau, or we call VHL from this point on forward. Thus, I'm excited to share with you our new protocol just launched last year that would be quite helpful to most of you who may have VHL-related pancreas issues. And after the lecture, which I only have about 6 or 7 slides, and I would want this to be more interactive, I will share with you some of the information about VHL, start with the brief summary of the disease, and then we're going to dive into some specifics related to the protocol itself that you may find this to be useful. Because I also want to announce, I hope you and your family members are safe from this COVID-19 situation. In light of this sort of crisis, you know, as one always says, that in any crisis lies opportunity to improve. And a chance of us to improve is telemedicine. And I'm happy to announce that NIH will offer telehealth consultation to all the patients across the globe. And this way we can see you as long as we have your imaging studies and histories and so forth sent to us electronically. We can offer the consultation just like you're seeing me today. And with that, we'll have that on the record, and we invite you to come to see us in person when it's convenient to you. So something coming out of this crisis, and I think this will be a new era of the telemedicine. Without further ado, I will share with you a few slides, and I will go through what we have to offer, and then we'll answer all of your questions that Mr. Mann will be managing and moderating the session. So as the title indicates, we're going to talk about the natural history protocol of patients with von hippel-lindau who specifically has pancreatic manifestations. Just to introduce you, and many of you know this really well, yet again, I'm going to just present to some of you who may not be so familiar with the disease. It is inherited cancer syndrome or tumor syndrome that happens quite frequently. You know, if you look at a big scale, the most common inherited tumor syndrome would be neurofibromatosis type 1, which is 1 in 3,000. So VHL is considered a rare disease, and that affects about 1 in 36,000 live births today. But if you consider how many people in the United States born every day or every year, there's quite a few people born with VHL as well. So if you see on the panel figure on the left side, it's a syndrome that affects many parts of the body, ranging from neuro, which is the brain and spine, eye disease, and also tumors, specific tumors that has features of we call neuroendocrine, which is a part of tumors that are susceptible for the defect caused by the VHL gene malfunction, which I will show briefly next. With that, these cells are more prone to form tumors as they feel that the lack of oxygen. And these tumors also have the same basic characteristics. As a result of that, they tend to be very rich in blood supply. And the tumors we're talking about here for the brain is very unique types of tumors called hemangioblastomas. Same with the eyes, and that's why when when the ophthalmologist looked at people with VHL that did not know they had a VHL, they could make a diagnosis right away. So it's a very characteristic. With that, we move down along the spine or around the actual central axis of your body. There are a number of nerve cells that can form tumors called paraganglioma, and more commonly, though, is a pheochromocytoma, which is in the adrenal gland where these neuroendocrine cells live. Next to it, in the middle, pancreas. Pancreas also has neuroendocrine cells. And with that, any part of the neuroendocrine cells in the pancreas can form tumors, and they often multiple. So this is part of the main interest that we have at the NIH, particularly in my section, that we're interested in neuroendocrine tumors, so the pancreas related to hippel-lindau disease. Next to the pancreas is also the kidneys. You see in the book, as you know, this is the main cause of problem in patients with VHL because they could develop kidney cancer, and that could be a life-threatening event if not managed properly. Because a lot of these kidney cancers can come in multiple times over the years of your life, then it can be managed in a different ways that I'm not going to focus today. We have a really fantastic urology oncology branch and their colleagues who essentially started the whole VHL project around the world, because the gene was actually discovered here at the NIH by Dr. Martin Linehan and his group. So we have had good experience with them, and they're probably the world's best experience to answer your questions about kidney cancer, and they have great success with that program. For my part, I'm emphasizing only for the pancreatic disease at this point, but I'll be happy to answer some of the questions that may be relevant to the pancreas or adrenal glands that I'm familiar with. So with that said, a VHL is autosomal dominant, which means it's a 50% chance that one could pass on to the next generation, and the offspring, that is. When we look at the clinical picture in general, we subcategorize the von Hippel-Lindau disease into basically two major types, type 1 and type 2. And that is based on the risk of developing pheochromocytoma. What I meant initially about paragangliomas are the tumors just like pheochromocytoma but occurs outside the adrenal gland. That is not common in the VHL, but we do see them every now and then. So type 1 is you have low risk for having pheos, and if you look at it, type 2 is you have risk of having pheos. And within type 2, you can look at how much is the risk of developing renal cancer. 2A, you have low risk. 2B, you have high risk. And 2C, you virtually only have pheos. What is it that is relevant to our talk today is type 1 and 2A, 2B, where you could see that the phenotypes of pancreatic neuroendocrine tumors in abbreviation called PNET can occur. And why is it important? Because if you think about this, what could affect pancreas and to some extent kidneys or brain in patients with VHL disease, it comes into two main types. One is cystic degeneration, meaning the organs develop some cysts within it. Cysts don't turn into cancers. Cysts don't really cause major problems unless it's really, really big, or it overcomes and replaces the whole entire organ. They would have organ dysfunction. But that by itself is a mechanical issue. It's not something progressively or can spread or can hurt anybody because they become tumors. No, the cysts don't turn into tumors. The part that we care more because it can cause health issue is the tumor part, which is what we call neuroendocrine tumors in the sense of pancreas. And that's what the PNET stands for. In kidneys, obviously, they all are kidney cancers. Thus, yeah, when one look at what to do in terms of prioritization, so you can say, oh, there's so many tumors that could happen, and obviously many patients have multiple types of tumors. What do you prioritize in terms of care? Obviously, kidney cancer is the main cause of problems and leading cause of death, so that needs to be first prioritized if you have one of those, followed by neurological tumors, because it's in the confined space of skull and spine. If we don't do it, at the timely manner or at a certain time that needs to be done, it can affect and cause permanent disability. And that leaves the pancreas to be the third prioritization. Of course, the eyesight is important, but I tend to view that separately. Pancreas will be the last of these tumors that we should be prioritize or concern, and that's because neuroendocrine tumors tend not to do bad behavior. In other words, they tend not to spread. Only about 15% or so, and that is in selected cohort, would have evidence of metastases, and that's what leads to surgery, and that's where we come in. But because we don't know who are at risk, and that is the subject of research at this point, and that's pretty much the whole purpose of the program. So if we look at, I'm not going to go through in the very specific details of what is the VHL genes. Essentially, people with a mutation in VHL genes could lead to malfunction of the gene. VHL is a tumor suppressor gene, which means it suppresses the growth of the tumor. When the genes malfunction, one would be susceptible to form the tumors I mentioned in previous slides. If you look at the genes and all the cartoon pictures, what essentially it says is that VHL works with other molecules in every single cell of your body. The idea is there's a molecule that occurs when the cells breathe and having oxygen, throughout their living life. That chemical signal normally gets degraded, and then the cell would, have the signal that is in balance, if you will. Not too much, not too little. It's in perfect balance. When the VHL gene is malfunctioned, what happens is this signal is not properly degraded, and that causes accumulation of the faulty signal. When that faulty signal is accumulated in the cells, and certain cells are more susceptible for this overproduction or overaccumulation of this faulty signal, it makes the cells think that it is starving of oxygen. With that, they try to survive, and then they induce all other features to make them survive, and one of which is to grow blood supply to it and multiplies and replicate. So that's how, in brief terms, this is how the protein malfunction as a result of the defect of the gene can lead to tumor formation. Specifically, when I'm talking about tumors from the pancreas, we have learned a great deal over the past many years. The protocol has been open since 2013. I'm sorry, not 2013, 2003. So we have been working with the pancreas for a long time in various subjects and various objectives. So just to highlight some of the recent papers that our group has published, shown there, essentially the diagram basically shows what we have learned so far. If you think about it, looking back, many of you may know when it comes to the size of the tumor, such as in kidney cancer, there's a magic number of the 3 centimeter that puts someone at risk of spreading from, having a tumor spread to other organs from metastases. When the tumor spreads, it tends to cause an organ to malfunction. If it keeps growing, then a person will die. But because you can't just take out the kidney preemptively, one would need to be on dialysis if they run out of kidney. Certainly, every time the doctor goes in and take out the tumor from the kidney, it causes in some way a damage to the kidney, and you would want to pick when to do it. And that's when Dr. Lenhans and his group studied that, virtually nobody with tumor smaller than 3 centimeters would ever have a spread. And that led to the practice of taking care of the tumor when it's needed. Can that be applied to the pancreas? We looked into that and we found a number of factors that can, that we can use to guide who are at risk of spreading. As I mentioned earlier, the spreading of the tumor in the pancreas is not as well defined as those in the kidney. Thus, we come up with some algorithm. Essentially, 3 centimeters still is the number that we go by in the pancreas, but pancreas is a bit different. In the head of pancreas, it's a busy place. There are many ducts and tubes, bile ducts, small bowel, and the stomach sits next to it. We could wait until 3 centimeters if we only think about, okay, it's the risk of spreading is 3, so, wait until it's 3 and then we can deal with it. But the problem is if we have to deal with certain type of tumor that big in the head of the pancreas, one would need a much bigger operation and complicated reconstruction. So we're thinking if we're 2 centimeters in the head of the pancreas or so, we could just go in and chill out the tumor and avoid the major big operations that could change one's life and how one eats. And that comes in to the cutoff of 2 centimeters head and 3 elsewhere for the pancreas. But as far as the risk of metastasis, we still think of 3 centimeters as well. But if you think about it, it's really not that great, right? One size fits all doesn't seem like a 2020 modern medicine. So we figured there has to be some way to tell that better. And then we learned over time that certain blood groups tend to have more risk. Type O, for example, has higher risk of tumor spreading and needing surgeries and so forth. So we learned that over the years. With that, it comes down to the algorithm. Okay, who's not going to get tumor that spreads? We probably can watch it. Who gets a tumor with higher risk of spread? We probably should intervene it surgically. That leaves someone in the middle. Well, there's some risk, but not too much, but certainly some. But how can we tell that better? So this comes to the second point of the diagram I'm showing here that comes up from our recent study. With the help of you guys as a patient, we learn a little bit more every time we do this. So of cohorts of over 340 patients now, half of those basically develop PNET with all the gadgets and tools that we have, and I will tell you a little bit more about the new up-and-coming tools that we have. We determine the risk of metastasis based on size and what type of mutations that you carry. So that can be a little bit more specific to you. As 2020, we want to be more individualized approach. In other words, it's a personalized medicine for you. So with that, we start with about 170 patients. Of those who have high risk for tumor that spreads, we would offer surgery. And we learned that those who have tumors smaller than 1.2 centimeters never get tumor that has bad characteristics. In other words, they never spread. So these people don't need to have tumor removed. And with that, kind of low risk, we don't even need to do scan every year. We could spread it out so that could minimize the risk of radiation exposure. After all, the best screening tool for pancreatic neuroendocrine tumors still is a CT scan with the IV contrast. Because that involves some radiation, we try to minimize the radiation by categorize who are at higher risk, who are at lower risk, and so forth. That leaves someone in the middle with some risk between 1.2 to 3 centimeters, and here's where the genetic information can be helpful. If you have a certain type of mutation we call missense mutation, what it is that when there's a missense mutation, the protein gets mistranslated and becomes a different type of proteins and causes the malfunction. And with that, one would be at higher risk for tumor that spreads. And also the third location, let's call exon 3, would be at higher risk. That was based on prior studies. If we don't have the missense mutation in the patients, we would say that they have low risk for metastasis, and that can fall into less intensive surveillance regimen. So we looked into a small sample size that we have had, and we think this is a good way to go. But we don't know how it functions as a prospective cohort in general in the bigger cohort, and after all, this is what we're looking back. If we're going to implement this approach, we need to know going forward whether it is helpful, if it's accurate, and that is the crux of the new protocol, where we are going to implement such the approach. Thus, our research questions, not only are we going to try to implement what I just proposed, but I also have ability to offer what we call gallium dotatate scan, which is a brand new scan specifically for neuroendocrine tumors, whether it's a pheochromocytoma, paraganglioma, or neuroendocrine tumors of the pancreas. And it's not just a VHL, for any neuroendocrine tumors as well. We have a great experience with the 68 gallium dotatate. We conducted a study prospectively over 318 patients that led to the approval of the gallium dotatate by the FDA as of a couple of years ago. So we were the ones who made this available, and now every institution, most of your institutions at home would have gallium dotatate as a tool to use in any neuroendocrine tumors. But our specific question is, what is the role of 68 gallium dotatate in patients with VHL-related pancreatic tumors? What we have learned of that small subset that had gallium dotatate with the VHL cohort, we found that it can pick up a lot of things: brain tumors, kidneys, POs, as well as neuroendocrine tumors in the pancreas. So we're not quite sure whether that affects how we make a determination if one could go for surgery or one could be observed. Thus, we incorporate 68 gallium dotatate to patients with the VHLs, particularly if it's within the low or intermediate risk group. If it's a high risk, well, we're going to do surgery anyway, but we want to make sure there's no disease outside the pancreas, and that's a different purpose. So the question really was, what's the performance of all of these screening and surveillance strategies plus the 68 gallium dotatate, and how does it affect the clinical outcome and overall, well, your life expectancy, and how it affects the disease course of the pancreas. To tag along with that kind of objective, we also have a brand new that hasn't been studied before in pancreas-related issues from the VHL disease. We're going to try to see if a various liquid biopsy using fancy and high-tech molecular markers that we have learned can help predict the early metastases. And that is nothing much more than asking you for a few tubes of blood and a cup of urine. And with that, we're going to try to triage what can we detect in the blood and urine instead of, getting a biopsy or go by the size. We can be a little bit more precise. And along the way, we hope we can learn what takes the tumor to metastasize. So these are adjunct translational endpoints that we can learn and make progress in such the protocol. And without help from patients like yourself, we would not be able to advance science and in return, bring the knowledge back to you and your family members. So I'm hopeful that, this introduction to the new protocols can be something that you and your family members are interested in. As I said, we can offer remote consultation as well. And that's not just in the COVID-19 era, but from this point on forward. So with that said, we summarize the algorithm that we proposed in this particular study. So first, we're going to do all the imaging that I mentioned, depending what kind of tumors that you have. If you don't have tumors that involve the pancreas and only have cysts, certain imaging will not be required. In other words, we don't need the dotatate if you don't have pancreatic neuroendocrine tumors. With that, we can just follow you if you would develop it or not, and you would be a good control group. And we do some blood, some urine, and we can also offer a genetic counselor if needed. Once all initial evaluation is done, we will categorize patients into low risk, which means small tumors or cysts only, high risk for metastases, or unknown risk, meaning if you have tumor bigger than 1.2 centimeters, or if it's new tumor, we don't know how it's going to behave. We put you to the unknown or high risk, and with that, we offer the surveillance program based on the risk. If we don't know what kind of tumor you got, or the tumor is intermediate size, we will do scan every year for now, and then from that point on forward, because we want to validate whether it's true about the genetic information. We want to make sure that it still works. So for now, we're going to ask for 1 year, and we will work with the adjustment if we see that to be true. So for now, in light of the unknown, we will put those who are at intermediate or high risk at 1 year surveillance follow-up, which many of you are familiar with. But with that, we can do every 2 years for the low risk, which we often do every 1 year. So now we're going to spread that a little bit more. And for those that have some suspicion of the tumor being more aggressive, we have all sorts of tests that we could offer, and that also could lead to surgery as well. So you see that we have the whole package plus the novel isotope studies that is going to be useful, I hope, and we'll learn from that. How can we use that to be of your benefit? And with that, I will conclude the presentation, and I welcome any questions or concerns. I'm going to unshare the slide.
Thank you, Dr. Nilubol. We do have a few questions. For somebody with VHL, how do they know what type of VHL mutation they have, and how would they go about finding out?
That's a great question. So typically, the type of VHL would be based on clinical presentation. In general, there are certain types of mutations that you could see in the genes that are more susceptible to cause one to another. This is where genetic counselors can be helpful to guide what to do, or if you find those providers who are familiar with VHL, they can guide you through. There are specific guidelines to screen. Even we know some genetic information that are associated with certain type of presentation. We can't just ignore that and write off that, oh, because you have this type of mutations in your VHL, you will never ever get that or this. In general, we would have a screening mechanism, say at the age of 7, you should have started to have pheochromocytoma screens and so forth. At the age of 12, pancreas should be screened and so on. And that is based on prior knowledge that will have, and again, you know, this type of information can be available to you by your provider. To make it practical, if you or your family members have VHL mutations in your genes, you can seek the providers and they will guide you through what type and what age, what type of screening mechanisms and at what age should be done. And that will triage one person to a specific type of, you know, VHL. It's more so for the research that we can group that together and talk about the same language as far as what group belongs to which one. But for screening process, it has been characterized and what should be done at what age.
So we have a question for peanuts that are about 1.2 centimeters. Would they cause any noticeable issues?
In general, no, because these tumors are considered small. Pancreas is rather big organ. It's unlikely to have one of two things when you're talking about peanuts in the pancreas. One would have the question: is it going to spread, or is it going to produce excessive amount of hormones? As you may know, pancreas produces a lot of hormones, insulin, glucagon, and all sorts of things. Of over 340 patients that we have had, half of those had peanuts. None of those had tumors that produce excessive amount of hormones. So you can take the extra production of hormones out of the equation. It doesn't happen. So that leaves to the only one features that we need to know. What is the risk of the tumor to metastasize? Based on the size, that would be low. But you would be at the, you know, at the junction where below 1.2, definitely low risk, 1.2 or above, you become intermediate risk based depending on what mutation you've got. So at that point, if you exactly have 1.2, we would aim on more cautious side and have that surveyed every year. But from the tumor standpoint, the size of that should not cause any pain, discomfort, or malfunction in the pancreas, or cause any compression issues to surrounding structure. It's still fairly small.
Now, another question here is for patients who have known kidney issues and they're getting MRIs for their kidneys, are those same abdominal MRIs good for evaluating the pancreas?
In the short answer is good enough to detect something large enough in the pancreas that can be clinically meaningful. We learned that MRI isn't as sensitive as a CT scan in detecting neuroendocrine tumors in the pancreas, particularly small ones. So you may ask, what's the point of knowing the small ones? If we say MRI could detect, you know, some of the things that are reasonable size that we should care about. It can be important in light of, okay, if you start seeing things in the MRI and you don't know where it starts, so you don't know the velocity, how fast it grows. If you look at a CAT scan, you could pick up 2-3 millimeters in size. MRI may or may not pick those up. And over time, you could, okay, you have 2, 3, 5 millimeter tumors. You can still do every couple of years. And then 10 years from now, it becomes 1.3. So you know that your trajectory is pretty slow. As opposed to, boom, MRI, you've got 2 centimeter tumors, and we don't know where that comes from, and you didn't see it 3-4 years ago. They'll say, oh, geez, it must have been coming from 0 to 2 in a very short time. So we still prefer to have CAT scan as it gives you more sensitivity, but many times we allow just the MRI in the absence of something really big that we need to intervene, if you will. But in the perfect world, if we could have any test, one test of pancreas, I would favor that to be CT scan of the pancreas.
Well, so considering the current situation, Are VHL patients with PNETs more at risk for coronavirus?
No, no, not at all. Not that we know of. This gene doesn't, as far as we know, this gene doesn't cause anything that would make you more or less susceptible to the infection, whether it's a virus or other kind.
Now, for patients with PNETs who are in the monitoring phase, but their appointments might have been postponed or pushed off due to the current situation, do you have any advice for them? Are there any questions they should be asking?
So that's a great question. As you may have seen, the release and the email that Ms. Sussman has sent out from the Alliance regarding the current COVID-19 and the surveillance program. As I mentioned, most of these neuroendocrine tumors are slow growing. The short answer is I wouldn't be too worried about it, especially we can see that, the trend of COVID is starting to come down. And I think you would be okay just to push off until it is safe to do imaging again. I think it is more risk if one would go on to places where people would have had or could have had spread the virus. And that would be more at risk for your health than having any concern about PNETs that grow over the past few months.
Thank you so much, Dr. Nilubol. I just want to thank you again for taking the time to join us today, as well as everything you do for VHL patients. We really appreciate it.
Thank you for having me, and you all stay safe and stay at home if you can.
Thank you. And for all our viewers, I want to invite you to join us for more upcoming events in our Surviving and Thriving Together series. You can find more information at vhl.org/together. And until then, stay safe and have a nice day.